Board of Directors. Today's meeting is officially called to order. Please note for the record that Dr. Michelle Morse is representing Dave Shoxey. Scott French is representing Stephen Banks, and Philip Wadley is representing Deputy Mayor Melanie Hartzog, and Dr. Michael McRae is representing Dr. Chinazo Cunningham, all in a voting capacity. Next on the agenda is the adoption of the minutes for the board meeting held October 28th, 2021. Are there any questions or comments on the minutes? Hearing none, let's have a vote on the minutes. Dr. Morse? Michelle?
Yes.
Thank you. Dr. McRae?
Yes.
Thank you. Philip Wadley?
Yes.
Scott French?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Piñero?
Yes.
Denioski Peña Mora?
Yes.
Anita Kawatra?
Yes.
Yeah, thank you. And Jose Pagan, yes. So the minutes have been approved. During the executive session, the board received and approved oral and written governing body submissions from NYC H&H Harlem. The board received and approved semi-annual governing body reports written submissions from NYC Health and Hospitals Metropolitan. In terms of Vendex approval, since we began the process of approving contracts prior to Vendex approvals, there are 15 items on today's agenda requiring Vendex approval, of which 11 have that approval. There are 8 items from previous board meetings pending Vendex approval. Since we last met, we have received 1 approval. We will continue to notify the board as outstanding approvals are received. So let me move to the resolutions now. Item number 2 in the agenda. So I'll read that one. And it's authorizing New York City Health and Hospitals Corporation, the system, to enter into a best interest 5-year renewal agreement with Coordinated Behavioral Care IPA Inc., CBC, for case management of system patients with persistent behavioral health issues at a cost not to exceed $17,977,600. This was presented to the Medical and Professional Affairs Committee November 1st, 2021. Please.
So,
Baron.
good afternoon. I'm Dr. Charles Barron. I'm the Deputy Chief Medical Officer for Behavioral Health Services for the New York City Health and Hospital System. In this resolution, many health and hospital patients with behavioral health needs are high utilizers of acute care services, but are not often engaged in ongoing ambulatory behavioral health care. The successful transition from psychiatric inpatient and/or emergency department treatment to a community-based setting for adults with serious mental illness requires skilled and intensive care transition services. The New York State Office of Mental Health, OMH, Medicaid Performance Opportunity Program, or better known as POP, mandates clinical partnerships between payers, healthcare providers, and care management agencies to provide this intensive care transition services to manage behavioral health patients with high acute care utilization. OMH recommends the critical time intervention, or CTI model, as an evidence-based and time-limited intervention as the preferred model of care. OMH endorses and funded a Pathway Home pilot project in CY 2018 to 2019, which was implemented at 2 New York City hospitals, one of which was New York City Health and Hospitals Bellevue, in partnership with the Office of Behavioral Health. Coordinated Behavioral Care, or CBC, is a provider-owned and led nonprofit organization consisting of a Medicaid health home, an independent practice association, and an innovations hub, which develops and incubates new program models such as Pathway Home. CBC is a nonprofit entity, cannot be certified as MWBEs under New York State or New York City law. As CBC is a nonprofit, they are exempt from MWBE goals. However, their staff at CBC is 85% minority and/or women, and the CBC Board of Directors is 75% minority and/or women. Pathway Home's goal is to ensure uninterrupted and coordinated access to behavioral health and physical health services while addressing the social determinants of health. CBC acts as a single point of referral to multidisciplinary teams of care management agencies at CBC's broader IPA network. These teams maintain small caseloads and offer flexible interventions where frequency, duration, and intensity is tailored to match the individual's community needs and have the capacity to respond rapidly to crisis. The Pathway Home programs meets OMH's recommended CTI model requirements by providing multidisciplinary and high-touch care transition services beginning prior to hospital discharge. These services continue into the community for 6 to 9 months after the initial engagement. Pathway Home is the winner of numerous awards, including Crane's Heritage Innovation and Healthcare Delivery Award in 2019, and the Case Management Society of America's Case Management Practice Improvement Award in 2019. Based on the experience of the OMH pilot at New York City Health and Hospital Bellevue, One City Health, a subsidiary of New York City Health and Hospitals, entered into a 15-month agreement with CBC beginning in June of 2019 to extend Pathway Home services to 4 additional health and hospital behavioral health services at New York City Health and Hospital Metropolitan, Harlem, Lincoln, and Coney Island. The agreement was approved by the One City Health Executive Committee and the One City's Board of Directors with a not to exceed amount of $4,294,476 funded through the Delivery System Reform Incentive Payment or DSRIP program. The contract was further extended through December 31st, 2021, with H&H funding approved by the Clinical Services Planning Committee. In March 2021, OMH declared an extension of the top mandate. With this extension, OBH recognized the need not only to extend the service, but also to expand the service to a larger group of eligible patients from the H&H risk pool. The program will move from a hospital-based to a borough-based model, with CBC playing the role of a single point of access for referral, as well as for 24/7 on-call access. If approved, the service will reach eligible health and hospital risk pool members who will be discharged from all 11 New York City Health and Hospital behavioral health and patient services. CBC will expect to enroll at least 90 to 100 patients per team per year. Under Operating Procedure 100-05, the system can renew a contract with appropriate vendors and pricing due diligence rather than procure when it is in the system's best interest to do so. CBC and Pathway Home teams have provided significant value to health and hospitals patients and inpatient clinical teams in transitioning high-risk patients into the community and engaging them into outpatient clinical services as well as community-based support. There are no competitors in New York downstate area, catchment area, who currently provide similar services. Initiating an RFP or a new service provider would require undoing the work done over the past 3 years and would present significant service gaps for this vulnerable patient population. To meet these goals, the Office of Behavioral Health is requesting a best interest renewal of the current agreement for the period January 1, 2022 through December 2026, with a not to exceed amount of $17,977,600. The pricing for the proposed and best interest renewal has no increase in unit cost. The Health and Hospitals funding supported by district earnings was approved by the best interest renewal by both H&H Clinical Service Planning Committee and the Contract Review Committee. And our cost details, which are illustrated, per team, each team per year costs $898,880. When you break that down, that's $832.30 per enrolled patient per month, or annualized approximately $9,987.60. This is for 90 to 100 patients per team per year. 73% of the cost is dedicated to salaries for the multidisciplinary care team. Each care team consists of 1 team leader, 1 RN, 2 senior mental health clinicians, 2 case managers, 2 peers, and appoint 2 contract manager. $3,595,520 is the cost for 4 teams per year, totaling 360 to 400 patients per year. The $17,977,600 are for 4 teams over 5 years, serving approximately 1,800 to 2,000 patients over the 5 years. Accomplishments at H&H include in the past pilot include 689 unique patients receiving Pathway Home services between February 2019 and June 2021. The patient engagement rate for this group is 68%. Of the 689 unique patients, the 30-day follow-up after hospitalization, or the FUH HEDIS EBT metric rate is 81%. The system-wide comparison was 47.4% previously. Reconnection to primary care and specialty services post-discharge was 90%. Connection to long-term community-based care coordination services such as health homes was 56%. Significant difference in the emergency department and inpatient visits between program participants when compared to the control group include the CTI group in the retrospective cohort design study averaged 5.3 visits within 9 months post-program enrollment, while the control group averaged 10.5 visits during the same look-back period. Similar findings have been reported in other published studies on the Pathway Home programs. A recent CBC study of Pathway Home members, of non-H&H members, using Medicaid and Psyche's data of patients enrolled in the program indicated net savings of approximately $41,296 per member over the course of 18 months. When translating that figure into applied over a 12-month or annualized period, the savings per member were $27,530.67. 400 members served in 1 year times the 5-year period of the contract, that means 2,000 members. So when you look at the savings of $27,530.67 times 2,000 members, you get $55,061,333.33. Or when you take away the cost of the program, the return on investment is $37,083,733.33. A brief overview of the Pathway Home program, the distinguishing features. By beginning engagement before discharge of the patient from an acute care setting, such as an ED or CPAP or a hospital admission, this team-based model will provide high-risk patient population with support within the community to connect them with outpatient clinical services, as well as to social services. The Pathway Home team members meet with the patient at least once a week for the first 1 to 3 months, accompanying them on the day of discharge and to their subsequent mental health, substance use disorder, and primary care clinic appointments. The visit frequency is always based on patient needs. The intensive care management model aims to strengthen community-based care through the development of individualized longitudinal care plans, as well as focus on skill building. The goals of the program include strengthening community-based care and improving connection to outpatient services post-discharge, reducing avoidable readmissions and emergency department use, shortening length of stay, increased enrollment in health home care coordination to maintain ongoing case management post-intervention, and increased medication adherence through medication management and reconciliation. The referral criteria to the Pathway Home program, the target population for the delivery of services enrolled by CBC will be individuals identified by health and hospitals who are being discharged from psychiatric inpatient units to the community. Clients must be discharged from the emergency departments will also be eligible. The minimum criteria include identified and referred from an H&H facility, significant challenges or disabilities or difficulty engaging in community care due to a SMI diagnosis, 18 years of age or older, They are candidates with serious mental illness who are high risk of acute mental health services. The criteria being 3+ mental health admissions and or 4+ emergency departments visits in the prior 12 months. Also being flagged in the OMH top high utilizers in their database psyches under both the high need population and the quality flag filters. They are not enrolled in another program that offers duplication of services such as the Assertive Community Team or ACT teams. They do not have dementia, neurocognitive disorders, primary disorders of substance use disorder, or primary disorders of personality disorder. And the emphasis will be placed on Metro Plus, Health First, and no insured self-pay. And I'm happy to answer any questions or comments.
Thank you so much. Yeah. Let's Sally Nandes Piñero
Yeah.
first.
I just, maybe I just have questions that are really clarifications. This is a best interest renewal contract. Contract has been renewed twice before, not this precise dollar amount or term, but you've had 2 prior approvals. And you say that downstate, you don't have a comparable service provider. Great, I lost it. A comparable service provider. So why wouldn't it be a sole source contract, I wonder?
I'm sorry, why wouldn't it be
A sole source contract?
we were recommended to go basically.
Oh, it's probably those lawyers. Okay.
It is. I would say the sole source criteria is super narrow, but this is
The best
very
route.
similar kind of
Right.
approach.
Okay. The
Sorry.
per patient cost is about $10,000, and you compared it to, I'm sorry, I lost my contract here, to another service, and you ended up, that would have cost $55 million, and there was a spread. Do they offer the same, it confused me, because you said there's no one that offers the same services, but you compared it to something else, which makes me think they've offered the same services, so I'm confused
Let me-
about the comparison.
Okay, I can serve. Actually, in both, it was CBC, the organization that we're contracting with,
Right,
that did a study of people that they had done that have been in the Pathway Home program, not H&H, other patients in other systems that
Right.
they worked with, using the Medicaid database and the psyches database, which is all Medicaid database. So it was not our patients, it was a comparison that they had done separately from us to see what the savings was, and this was what they came up with for the approximate 27,500.
so whoever was providing the
It
services
was the
was
same.
charging 3 times as much?
No,
No,
that's not the cost, that's what we anticipate in savings by them doing this and avoiding using our high acute care services.
right,
The cost of the contract is actually the same exact amount that we had paid under the district.
okay, so that differential, that spread, what does it represent? Where is that differential in payment? To whom is it being made? Or
Are you
where,
talking about the savings?
the savings?
Yes.
Right.
The differential is that of looking at prior use of emergency department and inpatient services. And then
Okay,
with the Pathway Home program, the number of them that are avoided that do not happen
okay,
over that period of time.
okay, I
If I
understand.
understood it correctly, it goes down by about half, right?
Yeah.
Goes down from 10.5 visits to 5.3 visits over, a certain time period.
Yes.
Dr. Barron,
So, Barbara Lowe?
thank you. I'd just like to point out, I'm very excited about this particular contract and services when I look at the young people. And there is some value added here if we can make sure we really embrace those young people and help them transition to adulthood feeling like leaders in their community with skills. I've even had the experience with Mothers Against Violence Sally out of the Dinkins office. exposing a bunch of kids to critical incident stress debriefing training with the trainer from Harlem Hospital, Injury Prevention, Barbara Barlow's program. They got it. We now have 3 of the young men, police officers in Washington Heights
Oh,
precinct.
wow,
That's great.
that's an amazing story.
There will not ever be another Kiko Garcia killing in that community because of that.
Yes.
And the women who were empowered because there was the right intervention and support. We talk about various things we need to do, which should be done relevant to what's occurring. But when we talk about young people, look at what we get back. Particularly when they meet us, know us. And thank God, Alan Rosenfield at Columbia, my former boss, gave us the medical school classrooms during the summer for the training.
Well, along those lines, you've got program goals. And I was wondering if like once a year or so, you could just submit how you're doing on each of one of those goals. Obviously the contractor can do that. It'd be
Yes.
helpful to see how close we come to achieving those goals.
Yes, we can submit an annual report to the board on this. Yes.
Okay, thank you.
So let me go through the list of board members here just to be thorough. Dr. Katz, do you have any
Yes,
questions?
no questions.
Michelle Morse?
No
Michelle?
question, thank you.
Thank you. Michael McRae,
No questions.
Philip Wadley,
No questions.
Scott French,
No questions.
Robert Nolan,
No questions.
Fenioski, Peñamora,
I just
Anita-
want to say,
Anita-
can you hear me?
yes,
Yes.
go ahead.
Yes. Okay. I just want to make a comment that I really appreciate in the presentation that even though the non-for-profit are not subject to the MWB goals, that the demographics of the employees and the board was included to really showcase how diverse this group is and take in consideration all the patients that they see and that they support. So I just want to, again, provide that comment of support for what they did.
And Anita Kawatra,
No questions, thank you.
thank you. And I guess I'll just say, I think this is fantastic. The idea that we are doing case management for these very complex cases has a lot of potential for the system. And, if we can get the data at some point that tells a story, not from what they have done, but what they have done with our population, I think that could be very useful to us as we move into more complex contracts and so on. I mean, that's a lot of people just need a lot of hand-holding through the system, and this seems to provide that. So on that note, let's take a vote. All in favor, please say yes.
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 Opposed, say
Yes.
opposed. Thank you. Opposed, say no. So the resolution passes. Thank you so much, Dr. Berg.
Thank you.
So the next one is, let me see. It's authorizing New York City Health and Hospitals Corporation, the system, to sign a 10-year lease with Coney Island Associates Retail 2 LLC developer for approximately 2,500 square feet on the first floor of a to-be-constructed building at 1707 Surf Avenue between West 17th and 16th Streets in Coney Island, the premises, to house the Ida Israel Community Health Clinic, the clinic, operated by NYC Health and Hospitals Coney Island, the facility, now operating on an adjacent lot for a yearly rent of $30 per square feet, to be escalated by 10% every 5 years, plus a share of increases in developers' operating costs, provided that the developer will build out the premises to the system specifications with a budget of 250 square foot square feet. Rent will not be payable until 18 months after construction is completed, and the system shall hold 2 5-year options to renew the lease at 95% of fair market value with the rent over the initial term totaling $787,500. That was approved by the Capital Committee on November 15th, 2021.
Good afternoon, Chairman, board members. My name is Svetlana Litas. I'm the CEO of Coney Island Hospital. I'm here with Christine Flaherty and her amazing team. So a little bit of background on the Ida G. Israel Center, Community Center. We used to have a sizable community center on Neptune Avenue that was destroyed by Hurricane Sandy. In 2014, the Board of Directors approved a license agreement with NYC HPD for the temporary occupancy of 7 lots on block 7061, which was nearby the original community center. It is a temporary prefabricated structure where we currently provide the services that were originally provided at the Ida G. Israel Center. In May 2021, we came back to the board for a renewal for the contract with NYC HPD. It was a 1-year contract with 5 successive terms, and it is at no occupancy fee. This particular block of space is in phase 3 of the HPD Coney Island redevelopment. While there's no date at this time for the development of this area, we do feel that making sure that services for this community are cemented and available into the future is incredibly important. And so therefore, move to the next slide. Therefore, we're bringing this for discussion today. So in December, the developer for this new construction will finance a phase 2 of the Coney Island redevelopment of the city-owned a block, which is 7062. It's across the street from our current location. It's $182 million in investment, and it will create 376 units of mixed use and affordable housing, and it will be financed by HPD and HTC. The building, which will have 11,000 square foot of retail space and 9,000 square feet of community space and facility space. This is an opportunity for us to make sure that the key services, primary care services, are available and maintained in the community going forward. It's a brand new construction. We will be in a corner unit on West 17th Street facing Surf Avenue. It's prime real estate. And there's quite a lot of local stakeholder support for a smaller version of Ida G. And we're talking about 2,500 square feet, which will be occupiable projected in 2024. So this is quite a ways into the future. In the meanwhile, we will continue to provide services in our current location. So this is how the services break down. Today, we have at the Ida G family medicine of about 4,000 visits, chemical dependency, which is about 13,000 visits, and dental, which is about 9,500 visits. Our plan into the future is to move dental to the main campus and actually to expand it. So right now we have 2 locations for dental, one at Ida G with 6 rooms, one on the main campus with, let's say, 2 rooms. The new plan will have 9 dental rooms plus 2 oral surgery rooms. So it's a significant ability to expand the service going into the future. The chemical dependency program would move to the campus as well as pending discussions with Oasis. And we have several years to really focus on what is the right thing for that program. And the family medicine program, which is primary care, adult and pediatrics, GYN services as needed, would remain in the community at 1607 Surf Avenue in the new 2,500 square foot space. It's going to have 6 exam rooms, which will give us enough leeway to increase services as needed and to bring in specialty care on a sessional basis if that becomes necessary for the people. Next slide, please.
So next is a summary of our lease terms for this agreement. It would be occupying, as Svetlana mentioned, the 2,500 square feet at 1607 Surf Avenue. The initial base rent is $30 a foot, and that increases 10% every 5 years. So instead of annually, you're dealing with 5-year increments, which is kind of common in the market. The rent would commence 18 months after building completion. This really allows us to have a moment of free rent, which is good. It allows the improvement and the readiness and the opening of the site, which we like to see. And the annual occupancy fee over the 10-year period is a little over $7,000. The landlord, in this case, it's fairly straightforward space that they would be providing. We actually had them take a tour of one of our COVID centers of excellence so they could see the types of finishes we expected, the types of care rooms we want to provide. And based on the basic nature of that, they'll provide kind of the basic part of the fit out. We would provide them with some of the design to make sure that it's compliant and dealing with the filings associated with it for ambulatory care for Coney Island Hospital. And so this shows you from a standpoint of market rate, we feel like this is definitely a fair and reasonable market rate. There was a recent city transaction in the same neighborhood that landed at $32 a foot for 30,000 square feet. So we're definitely at or a little below the market, with also getting that improvement work built into the lease because it's a long-term agreement.
We're very excited to be able to make sure that key services stay in this particular area, which will only continue to grow with all the development that's happening around it. The space is going to be flexible so that as the community changes and grows, we'll be able to provide the services that community needs at a particular time. So I'm happy to answer any questions.
Any questions from board members? Sally Hernandez Pinheiro?
Okay, one, I think the center is extraordinary. I think it is like the prototype for how a community health center can operate and should operate, you know, in a footprint of just 13,000 square feet. In particular, I think Dr. Allen and her folks should look at your dental program. The fact that you can do nearly 10,000 dental visits a year, and how you're able to do that, I think is worthy of exploration. But congratulations to you, this is terrific.
Thank you, Sally. We're very proud of our dental program, which is why we're really looking to grow it for our whole community into the future. I think there's possibility to do that well.
Barbara Lowe?
I'm the advocate for the teens, of course. And since this is a
we can get a follow-up to you on that from Dr. Bodnar.
That'd be great. Thank you, Dr. Allen.
Thank you.
Okay. I was just wondering about what do you use the space for, maybe in the early evening to mid-evening hours?
The current space or
Well,
this space?
This one.
Well, hopefully for running clinic time for patients to work, and for to be able to have, you know, parents who work take their kids to the pediatrician in the evening. But you know, I think if the space is flexible, we could certainly talk about other uses for it.
Yeah. I'm just wondering what's happening with the young people in the geographic area who are constantly being subjected to losses and violence.
That's an excellent point where I'm happy to kind of explore. We currently, in the current IDG, we run a very active chemical dependency program, which services all ages and actually has a very, and now post-COVID is growing quite a bit. So I think they are engaging with the community very actively. And we're happy to consider other uses.
Your catchment goes how far? Do you go to Brighton?
For the chemical dependency, absolutely.
And who are the dealers? Young people?
Well,
Okay, I won't go. I'm gonna stop there.
Red lawn is out there.
I'm gonna stop there because I know the beer drinking of young people is pretty heavy out there.
That's true. On the other hand, we actually have quite a lot of issues with substance use in the geriatric population.
Oh, yeah.
And that is a very active issue in our community, and we're trying to engage the older folks to really bring the appropriate care to them as well. And, when you combine age and issues and language challenges, things become very complicated very quickly. So we serve the gamut.
So I'll also point out, because it's affordable housing and there's so many phases, we can collaborate with HPD as well, because there's always dedicated community space in addition to our small footprint.
Nice.
So we could, take your feedback and see what HPD knows the developers are or are not doing yet, and see if there's other opportunities, because I would think there should be other opportunities for other like-minded community groups.
They don't stay teens very long.
Yeah, they don't.
So any other questions from
Thank
board
you.
members? Thank you for that. Any other questions? Okay, so I'll ask for a vote then. Dr. Katz,
Yes.
Dr. Morse, Michelle Morse,
Yes.
Dr. Michael McRae,
Yes.
Philip Wadley,
Yes.
Scott French,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Fenioski Peña Mora,
Yes.
Anita Kawatra. Yeah. And Jose Pagan, yes. So resolution approved. Let's move to the next ones. Thank you so much.
Thank you.
I look forward to visiting facility.
We'll cut the ribbon together.
That's wonderful.
Yeah.
Thank you so much. Good opportunities there.
Have my hard hat ready.
Gotta put up some basketball nets.
So I'm gonna move now. I'm gonna move now to number 4 and Fenioski.
Yeah, I have to recuse myself. So I'm going to log off of the meeting. Colicia?
Thank you
is that
so
okay?
much. Yes.
Yes.
Okay. See
Thank you.
Thank you,
Thank you, Dr.
everyone.
Peña Mora.
Bye-bye.
Bye.
Happy
Thank you.
Thanksgiving to everyone. Happy Thanksgiving.
Yeah.
Saying,
Bye.
yeah. Okay, so number 4, authorizing the New York City Health and Hospitals Corporation, NYC Health and Hospitals, to increase the not to exceed amount for requirements contracts with 8 architectural and engineering consultant firms, namely Array Architects, PC, EFH Architects, PC, Gensler Architecture, Design and Planning, Gelter and Wente Architects LLP, Lothrop Associates LLP, Architects, Moody Nolan Inc., NK Architects, PA, aka Nadaske Coupleson, Perkins Eastman Architects, TPC, to provide professional architectural and engineering design services, the AE firms, and with 5 mechanical engineering and plumbing consultant firms, namely Greenman, Pedersen Inc., MG Engineering DPC, which is Cullen and Lemelson, Lakhani and Jordan Engineers, Lizardos Engineering Associates, and Loring Consulting Engineers, to provide professional mechanical engineering and plumbing design services, the EMEP firms, on an as-needed basis throughout NYC Health and Hospitals by an additional $60 million above the original $30 million, for a cumulative amount not to exceed $90 million. This was presented to the Capital Committee on November 15, 2021.
Good afternoon. Great to see you, Chair and board members. My name is Christine Flaherty, Senior Vice President of OFD. I'm joined by Oscar Gonzalez, our lead for capital development. The great news here, next slide, please, is that we have successfully advocated for and received more funding than anticipated before these contracts came into our eye. And so we're here today to increase that capacity, and I'll let Oscar run through the next couple of slides, but this is good news and exciting news for us.
Yes, thank you, Christine. Hello, everybody. So we initially started the procurement on this way before COVID, about early 2020. And obviously since then, we were able to get the contracts secured, and they were activated in January of 2021, so this year. So since then, we've been able to get the bond funding in place and secure with Morgan Stanley of $98 million. We were able to secure $1.2 billion of mayoral funding to be spent from fiscal year 22 to fiscal year 26. We've been able to secure borough president and city council funding for an additional $30 million. and we're only in November. So this, obviously, a lot of this funding is gonna go for clinical, critical clinical projects and definitely high priority projects. We have failing infrastructure. We have a lot of work to do, and it takes a lot of effort to do it. In addition to that, we've also been able to get awarded DCAS funding, ACE 11 grants were issued to us for multiple facilities. So that in itself is also a lot of work that's got to take place. In order to do a lot of this work, it's full life cycle. We have to do a lot of pre-planning. We have to take everybody's vision, be able to put it on paper, work with the architects, work with the mechanical engineers to be able to design everything, make sure it's regulatory compliance, DOH, DOB, FDNY, make sure that we like it as stakeholders as well. We need these drawings in order to be able to procure. We need these drawings in order to be able to get contractors on board and construct. So consultants are critical aspects to the success of these projects. But we don't have enough. We don't have enough consultants. So we, as we were mentioned, for the A&E and the MEP pools, we initially selected 10 consultants for the A&E, but only 8 of them we contracted with. 2 of them we weren't able to negotiate terms, and the other one, unfortunately, because of COVID, they just were not able to succeed with their business, so they had to shut down their business. For MEP, we were able to select 5 firms, and we contracted with 5. These were for contracts of 3-year terms with 2 one-year options. For the A&E was $18 million capacity, and for the MEP was $12 million, adding up to 30. And as requested earlier, we're looking to increase the capacity an additional $60 million to cover roughly $90 million in total. So the current contract pool is $30 million, as mentioned. There is a 30% MWBE utilization plan already in place. With the original proposals, they presented 47 MBE specialty subconsultants that they will use through the life of the contract. And for the MEP pool, again, same 30% utilization plan for MWBE, representing 38 MWBE specialty consultants for each firm. Christine?
The next slide shows you our current state among the pool of A&E firms. So we have over $4.5 million that have already been committed, dollars obligated, and we have over $9 million of additional work orders in the queue that have not yet been committed, which shows you really we only have a balance of $3.5 million left, even though this was set up as a 3-year with 2 one-year options. So it really shows you the burn rate here and the in a positive way that we're starting designs and getting them going and looking to start a lot of projects. And so the next slide shows you actual detail of the MWBE utilization of our A&E consultants. Our top 2 firms on the list, just to point out, those are the 2 firms heavily engaged in our outposted therapeutic housing endeavor that we're going to be presenting shortly. They have not had the capacity to compete for the mini RFPs that we've initiated designs on, but they do plan on participating in future designs as we wrap up their design activities on those programs. So that's exciting, and it's good to see that we have largely fairly high MWBE utilization of our architecture and engineering firms. I also want to point out there's a high number of work orders for one of the firms, and that's largely tied to the fact that they took on the firm that unfortunately had to close. They had ongoing work that had to be finished. And so they took on a large number of small work orders in order to help make sure those projects went into construction and had a designer of record to complete that work. And so that's the kind of explanation of the higher volume of work orders, albeit fairly small in value at times. The next slide shows you our MEP utilization. It's not burning at the same high rate as A&E, but it is burning pretty quickly considering that we're only about a year in at this point. And with the additional ACE grant funding that we have for energy projects, we do see this pool equally being used up at a fairly fast clip. The next slide shows you the utilization across the board of our MEP vendors and how much has been awarded, how much is MWBE participation. Next slide, please. I would point out that the MEP is a little more difficult at times to get MWBE participation because there's not always a high volume to subcontract out. If we're replacing a piece of equipment, and there's not a lot of new run or anything, there's not as much opportunity to subconsult. We are already planning a meeting with Loring specifically because they had a fairly low MWBE participation. Looking at their work orders, it actually is large pieces of equipment, but we will be working with them to increase their MWBE utilization. And the next slide is our resolution. We're happy to take any questions. We are excited about this increase to just ensure that we can keep the wheels on the bus. We're going to be looking closely at capacity utilization in the coming year. And it is possible that we could probably go out to the market most likely ahead of the 5-year term, just based upon this burn. But
Thank
we're
you.
happy to take any questions at this time.
Any questions from board members? Robert?
Yeah, I just asked that the record show that the company Moody Nolan in no way is related to me or my family in any way, so I will vote on this matter because there is no conflict. But I'd like to have that stated for the record.
Thank you
That's
for
what sons
clarifying.
of judges say.
important.
Yeah, it matters like
Thank
this.
you.
Yeah.
Okay.
Thank you. Any other questions or comments from board members?
Wow.
Tremendous work, really tremendous. Great
Busy times.
presentation, Oscar and Christine, great substance, just great opportunities.
Okay, so on
Congratulations.
that note, I'm gonna move to a vote.
City very soon.
I'm gonna move to a vote. So
It is kind of a city,
Dr.
20
Katz?
million square feet.
let's vote on the resolution. Dr. Katz,
Yes.
Dr. Michelle Morse,
Yes.
Michelle,
Michelle?
Oh, sorry. I was muted. Yes.
thank you. Thank you. Dr. Michael McRae. Okay. Philip Wadley,
Yes.
thank you. Scott French,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes,
Sally Hernandez Pinheiro,
Yes.
Anita Kawatra.
Yes.
Thank you. And Jose Pagan, yes. So resolution passes. Thank you so much.
Thank you.
Thank you.
Oh, I go next. Let's see, what am I? Authorizing, so number 5 in the agenda, authorizing New York City Health and Hospitals Corporation, the system to sign a contract with Consigli Construction Company, Inc., the CM, to serve as construction manager under a guaranteed maximum price GMP structure for the construction and construction management of the system's outposted therapeutic housing unit project at NYC Health and Hospitals Bellevue for a cost of $109,925,530, which when added to 10% project contingency yields a cost not to exceed of $120,918,083. This was presented to the Capital Committee, November 15th, 2021.
Good afternoon, Christine Flaherty, OFD.
And I'm Patsy Yang for Correctional Health Services.
Welcome.
So thank you. I'm going to start very briefly. I think the board remembers that in 2019 we first introduced this concept, this program, and have since come to you for authorization for contracts. Basically, the program, these outposted units, reflects that despite so many of the innovations that we've made since coming over to health and hospitals, there remain a number of patients in our care who are in custody, but who need regular access to specialty and subspecialty care that's only available in the hospital. And because the journey from the jails to the hospitals for care can be so arduous and quite disruptive, many of our patients decline what sometimes can be life-saving treatment to come to the hospital. So we had an idea, which we were delighted was approved and funded, to create secure units within hospitals that would be operated by us, that would actually house the patients who need such care and bring them closer to where the care actually is. So it's not a van ride away and bus in traffic and all of that. It's literally an elevator at most ride away. Sorry, I'm skipping the slides. The next slide will show that, really what this does is it creates a normative environment for our patients. It will improve access significantly, as well as quality and continuity of care between the correctional health service providers and the specialty providers who are in the hospitals. What this also does is it brings an infusion of dollars to the system in terms of capital dollars to the hospitals not only for constructing and renovating these units themselves, but all the prerequisite work that needs to be done in order to appropriately house these units, and an opportunity to upgrade and modernize some of the systems that are infrastructure to the facilities. It will also bring operating expenses to the hospitals for the overhead and ancillary services, the sports services, dietary, housekeeping, HVAC, that correctional health services will reimburse the hospitals for. These are unused or underutilized spaces in the hospitals currently. We're not taking away beds or any other areas that are for current patient care to the community. So that's a plus to the hospitals. These were approved before by the board, but because of the deteriorating circumstances and conditions in the jails, which I think everybody has increasingly read about, the sense of urgency to get these units constructed and open to accommodate the most frail patients in our care. These are mostly people who, if they were not in custody or when they are released, would go to a skilled nursing facility, for example, or assisted living, and are currently in our infirmary. To get them out of these very ancient facilities and in a place that is much more therapeutic. And I'm going to turn that over to Christina.
Thank you. So as Patsy mentioned, in November, this was announced in 2019. Can we go back? Making this an official project in our capital budget. During COVID, we progressed design services, program management services, 3 contracts we brought to the board. Those contracts have been well underway. That includes design services for both OTXHU units at Woodhull and Bellevue, program management services to support our OFD team and CHS in managing design and helping us additional staff to help facilitate the project. And then we had another design package that really involved the relocation of a number of spaces at Woodhull to free up the space and efficiently staff Woodhull Hospital. So the design has been well underway. The number of patient beds is listed there per site. And as Bellevue's design is wrapping up completion, based upon the deteriorating conditions at Rikers Island, the city identified the need to accelerate all of the program and asked us to really fast track Bellevue to complete it this coming calendar year. Capital money was identified to fund the schedule compression, as well as capital dollars for a new roof to replace Bellevue's roof on the H building was also identified in September plan and became available. And so we quickly accelerated our original plan for Bellevue Hospital and started fast tracking this project, including getting a waiver to allow a CM guaranteed maximum price contract delivery method, which normally the city does not have. We also were able to bid out an emergency demolition and abatement contract, which is under $5 million, to accelerate the demolition and abatement while we're bringing the construction management firm on board. And we also progressed this contract to bring it in front of the board. Thanks to our colleagues in supply chain and a lot of us, we've really accelerated the procurement process by 3 months to bring it before you today. So let's go to the next slide. That will give us more way of where we are for this. So the Bellevue project, we thought it would be a good moment to share with you kind of the floor plans for the project itself. This shows you the different units of the second floor. Everything's on the second floor except for the outdoor recreational space. And it shows you the inpatient beds. A pretty large majority of that space is the clinical space, as well as some circulation core and administrative space for our CHS colleagues, as well as DOC colleagues. It's a full gut renovation. It will also include full replacement of all of the windows and really create a beautiful normative environment, a better care environment, a better restorative environment for this vulnerable patient population. Next slide. Next slide, please. Also, there is outdoor recreational space that is required to be provided to the patient population. When the design team started studying the outdoor space that exists today, it was also realized that we have really a pre-existing condition of the Bellevue roof needing to be fully replaced. So we advocated and sought and received the funding dire funding needed to replace that roof. And so that was just recently added to the project, which will allow us to make sure that that's protected space for the entire building, much to Patsy's mention of making sure that we're getting some infrastructure upgrades that are benefit to the hospital overall. So that will be added to the scope here. Next slide. So a little bit about the scope of services for this contract that we're requesting approval on. This is a guaranteed maximum price build contract. This vendor will work for ourselves as well as ACOM, who will support our efforts to manage them. During the early phase of their contract, they'll be looking at the design, identifying any opportunities for fast tracking, identifying any long lead items, figuring out if there's any like slight modifications that are within reason and approvable to the end users to make sure we fast track this project. And then they're going to fully buy out the project, have all of the subcontractors under them. They're going to deliver the work in full by the deadline of full occupancy by the end of the calendar year. So really November is their key date to be fully ready because of all the inspections and regulatory sign-offs in order to occupy it by the end of the calendar year. Our role during this is we're overseeing the work with ACOM, making sure the work is done. I failed to mention we will be working 24/7. We will be working around the clock to get this done. And so with that comes, oversight of that, making sure it's happening, making sure we're working closely with our partners at Bellevue so as not to interrupt patient and care. We are fortunate that the second floor is not above an inpatient room. It is above an area that is an outpatient as well as office space. So that allows us to at least have some cushion within the work, but we will be working very closly on what's quiet work, what are the hours that will be appropriate for our colleagues at Bellevue. Next slide. The funding for this contract comes fully from City Capital. The target budget for our construction management is the $109,925,530. We have a $10 million project contingency listed. There's a duration of this contract is 13 months for occupancy with a December 1 start and a warranty period of 1 to 2 years. If they have to replace a specific element, that element that they replace has a lag on the warranty just to ensure that we have the quality required for the contracts. And so that's why the total time of contract is up to 3 years. Next slide. This shows you our RFQ and our RFP timeline. We got CRC approval for an RFP in July. We issued an RFQ at the early September. The RFQ was sent out to 17 vendors as well as City Record and Contractor Reporter. And we had a pre-proposal conference in mid-September. At such time, it was identified that we potentially might be fast tracking this project. Proposals came in. We have 5 proposals come in on October 4th. And the evaluation committee, at this point, we knew we had to try to fast track this project. And so very swiftly shortlisted the 5 proposals to 4 and had a on-site walkthrough at Bellevue on the 12th with the CM shortlisted firms. On the 14th, we issued the RFP with the draft contract, and we had a second pre-proposal conference so as to further educate them and all of the information. We also provided the construction documents, so the drawings, the 50% construction documents were provided to these vendors for them to provide estimated target price for this bid. So this was an iterative process. There was a lot of Q&A during that process as well from the vendors, but it was very fast tracked, and we were clear we had serious deadlines for them to get their proposals in. We were very happy to see 3 proposals come in after that iterative process on the 29th of October. The evaluation committee did interviews with the 3 firms that submitted their proposals. And on the 5th, the scoring was done. And Consigli Construction Company, Inc. was the highest rated proposal. So our criteria was listed here. This shows you the minimum criteria in order to qualify to submit in the first place. We wanted to ensure that these were organizations that had high volume experience delivering healthcare work and operating setting. That was very important to us. We wanted to see ideally some correctional experience, some public sector experience, track record on MWBE participation. And our criteria for scoring, really, we wanted to see the approach and methodology that they were going to take to build the project, the quality of their experience and the experience of their staff, as well as 15% towards their MWBE plan and 15% to the cost of the job. So those were the criteria used to do the scoring. The participation team that did the scoring themselves included members from Bellevue, our colleagues at EITS, OFD, our colleagues at Supply Chain, as well as Correctional Health Services, our client. Next slide. Consigli Construction is a new vendor for H&H. We have not worked with them in the past. We're excited about an opportunity to work with a new vendor. They're an employee-owned construction management firm, fourth generation, and they do a pretty large volume of work annually. They have 25% of their work is in healthcare, actually. So they have a substantial amount of experience in healthcare, just not at health and hospitals. They did demonstrate within their approach a very innovative strategies towards compressing the schedule. They had really the most aggressive posture about securing supplies in an early fashion and really just-in-time staging of supplies across the way in Long Island City in a warehouse so that they could ensure that they were feeding the job, as they call it. And so the approach, I think, and their experience in healthcare really made the evaluation committee feel very comfortable. And they also had a very pointed and specific MWBE plan within their proposal approach, which I'll talk to shortly. They had successful reference checks at Northwell Health, SUNY Stony Brook Medical Center, and Albany Medical Center. This shows you the MWBE utilization plan. They did commit to a 30% plan. They have to buy out the project, but they also had two partners that they identified as part of their core team. And Tech Engineering will help them on the virtual design piece of clash detection at the early stages. Padilla Construction is an MBE contractor who will help on general conditions. And they also, in their plan, really showed the different types of scopes of work within their buying packages that would be 100% MWBE, sometimes 30% MWBE, but they had actual vendors listed as part of their subcontracting plan. It was the most robust of all the firms that we looked at. So the next slide, I believe, is the resolution itself. I'm happy to take any questions.
One general question for everyone, for all the construction projects. Supply chain is definitely an issue. We know
Yes.
that.
Yes.
And you know, that could be a problem despite anyone's best efforts.
Yes.
What about workforce in construction right now? Is this a good, I mean, there have been periods of time, like early in COVID, it was actually an excellent time to construct things
Yes.
because there was very little construction going on. And so most firms had access to a large numbers of workers and could get a lot done quickly.
Yeah.
What is the situation at this time?
I think that we are hitting an uncertain, is it a cliff? How big is the cliff? I think that there's also been
A cliff meaning?
of resources. I think there's a lot of pent up energy in infrastructure and construction. I do think the healthcare market is kind of in a little bit of a different situation in that, you know, some health systems haven't done very much. So now they're in the planning phases. So I'm kind of hopeful we're grabbing this right before everyone else has finished their designs, frankly. I do think that there's work to be done on workforce development to getting more younger people into the trades. I think there's a huge opportunity within our communities and our neighborhoods to try to get more apprentices to the workforce, because that really is the way to deal with the attrition rate. I think we see it with our own staff, but we also see it, I think, in the private sector as well. And so I think it is one of the risks. I'm not going to tell you that there's a ton of people on the bench right now. I don't think that would be appropriate. I think there's people that are coming back to the workforce too, though. I think there's a sense of, you know, people had maybe some downtime during COVID, and I think that there are going to be, I think there is some workforce out there to be had.
That's good. I just think it's always important for people to adjust expectations to what the actual conditions are in the world.
I think that we're going to know probably by May if we're good.
Yeah.
That's how I see this project. I think we're going to really work really hard this winter, and by May we should know whether we're going to have the scary hardware or if it's, like we're not sure if it's gonna be the
Any-
material or the workforce, I think. And one thing we're also trying to be cognizant of is really learning the lesson learned of the other emergencies. So what is the size of the double shift? It's not a 24-hour thing. It's, 2 10-hour shifts and not all the time. It's some of the time based upon the need and what work is ahead. But
Any
it's a
other
good
questions, any burning questions from board members?
I'll be real quick, I promise.
Very quick.
Because I get a little confused between the Woodhull project and the Bellevue project. You've got a project manager contract for Woodhull and a construction contract for Bellevue. Do we still have to see the Woodhull construction contract? Has that not come to us yet?
Yes, that has not come to you
Okay.
yet. We are bidding out the enabling work for Woodhull. So that's probably the next thing you'll see for Woodhull, which is about the relocations.
Okay,
So that's out to bid right now. That should probably be next year resolution that you see, given our timeline for December. So
yeah.
that will probably be the next thing you see for Woodhull, although we're planning on thinking through our acceleration plan for Woodhull as well.
And
But-
will you'll have that same best value basis provision for Woodhull that you have for Bellevue?
Yes, our waiver we received for the CMGMP delivery method, we received it for all of OTXHU, both for
Great.
Woodhull and North Central Bronx.
That's great.
So,
That's
yes,
exciting to see how that works.
yeah.
And on a per patient basis, are the construction costs comparable between Woodhull and Bellevue? Or is Bellevue gonna be more expensive?
I think we need a little more time to figure that
Okay.
out. I think similar to this is a target budget. Also, we're gonna know a little bit more, and I'm happy to report to our capital committee debriefing times to kind of give you a rundown of how things are going at both of these important projects.
Okay, thank you.
Any other questions? Okay, so I'm gonna call
do
for the
have-
vote, Dr. Yeah,
I'm
go
sorry.
ahead.
I actually did do the electronic version this time, but I don't think it worked. Just one brief question. I know this
Yes.
is probably a couple of steps ahead in terms of the fact that we're in the construction phase, but I'm just curious, would these units then fall under the existing QAPI and quality improvement infrastructure that H&H already has across sites? I was just curious about that piece.
I can answer, yeah. Hi, it's Patsy Yang. Yes, these will be part of Correctional Health Services, and we are currently part of QAPI. We have been since we came over to Health and Hospitals in 16. So yes.
Thank you.
Yeah.
Thank you. Okay, so let me call for a vote then. Dr. Katz,
Yes.
Dr. Michelle Morse,
Yes.
Michelle. Thank you, Dr. Michael McRae. Philip Wadley,
Yes.
Scott French,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes,
Benioski Peña, I'm sorry, Anita Kawatra.
Yes.
Thank you, and Jose Pagan, yes. So I'm gonna then, because there's one presentation for the last two resolutions, I'll read those, and please be brief because I am concerned about the time.
Yes.
So the first one is authorizing New York City Health and Hospitals Corporation, the system, to increase the funding by $6,087,369 for its agreement with ACOM USA to provide program management services for the preparation of space at NYC Health and Hospitals Bellevue Hospital and NYC Health and Hospitals Woodhull Hospital in connection with the system's correctional health unit initiative to treat its patients who require higher levels of care in its outposted therapeutic housing units in Bellevue and Woodhull, such that the funding is increased from $9,039,198 to $15,136,567. And that was presented to the Capital Committee on 11/15/2021. Then the next resolution will be authorizing New York City Health and Hospitals Corporation to increase the funding by $1,814,880 for its previously executed agreement with Array Architects to provide architectural engineering services for the renovation of space at NYC Health and Hospitals Bellevue and NYU Health and Hospitals Woodhull Hospital over a 5-year term in connection with the system's correctional health unit initiative to treat its patients who require higher levels of care in its outposted therapeutic housing units, such that the funding is increased from $8,663,000 to $10,477,000. $477,880. Sorry, that was also approved in the Capital Committee, 11/15/2021. So Christine.
Thank you so much. So I'm going to actually point out that we presented these slides. The first beginning slides, myself and Patsy Yang presented all of the exact same verbiage. So I will not redo the background, and Patsy's not going to redo her amazing piece about the need. And so we'll just jump directly into these two requests. ACOM was brought on board as the program manager, extension of staff to us so that we could oversee this important project despite everything we were doing with COVID at the same time. So the program management consulting services really was to help oversee all aspects of this project: planning, coordination, constructability reviews, design management, schedule management, budget management, etc. And they were brought on as an extension of staff. With the schedule compression of Bellevue happening this fall, we really realized we needed a bigger boat and we needed more people. And while H&H is great, we can't resource up, and this is really the key place to resource up, is looking carefully at our partner, our alongside consultant that's really by our side helping us oversee this. So immediately they started getting some people with GMP experience and getting people identified. We actually gave the scope of the demolition and abatement for them to oversee that work that's already underway at Bellevue. And we expect double shift work with consigli happening at Bellevue once we hit construction. And we need them to provide inspectors and supervisors for that work all the time to ensure that we're really coordinating carefully with Bellevue Hospital and doing everything that's necessary to ensure that all of the work is done and that we meet the schedule goals and have stakeholder resolution for anything that could come up along the way, which is a guarantee. And so this is their scope. We also, in this type of heightened fast track environment, decision-making is critical as well. And so decision-making and facilitating that requires, the right team members on site every day and making sure there's enough team members that are able to pass the baton as the project is very dynamic. Next slide. So what this amendment is for is really a pointed 14-month duration specifically associated to the work at Bellevue. It's a not to exceed contract increase, and so we only will be billed against the staff that show up for the project that we approve to be working on the project. So this is really, they gave us a staffing plan. We know what the staffing plan is. Will we need every single person? We're not going to really fully know that until the job gets scheduled out and all the work is happening. But this does provide us adequate staffing to ensure that we have all the people we need on the project. This brings us to a total contract value of a little over $15 million. The funding of this is part of the capital plan and part of the capital dollars that did come in for this project. ACOM, during the moment of the contract award, had a 30% MWBE utilization plan. 10% of the ACOM's invoices today are MWBEs right now because their contract actually just recently registered, and so the risk of their services they carried on themselves as a prime. They didn't impose that on their MWBE partners. They're now ramping up their MWBE partners substantially, and this amendment actually increases their MWBE utilization in the field, and so they're actually looking at now about an effective 31% participation rate with this new amendment. And that concludes my request for ACOM. We're happy to take any questions specifically related to this amendment.
Okay, any questions from board members on ACOM, on the resolution? Okay, so I'm gonna go ahead, I'm sorry.
I just think it's amazing.
It's amazing. Yes, so let me then ask for a vote. Dr. Katz?
Yes.
Dr. Morse?
Yes.
Dr. McRae? Philip Wadley?
Yes.
Scott French? Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Anita Kawatra?
Yes.
Thank you, and Jose Pagan, yes. And let's move to the
Great,
last one.
last one.
Thank you.
So our next amendment is for Array Architects. They're our designer of the OTXHU units. They've been working really hard. So they had the full scope of both Bellevue and Woodhull. Bellevue we knew was always going to be ahead because the space was already empty. And so with this schedule compression, there's two pieces of the scope here that leads to the increase. One is now they have to design a new roof. That wasn't in the plan originally, so we're going to replace the roof. They need to do that in an expedited fashion. They've already started that work at risk to make sure that they can get those plans to Consigli. And so they have that scope of work, and also really the lessons learned from how you fast track projects is you have design professionals next to you helping approve decisions, dealing with technical issues that could come up, drawing sketches if you have an unforeseen condition, and giving direction to the builder. And you create that collaborative environment so that things can happen really productively and there's never any holdups. So with this amendment, the designer is staffing up. They realize they'll have to do faster turnarounds on submittals and requests for information, sometimes just in time, right on the site. They do have experience doing this for health and hospitals before my time, actually. They were part of the Carter. They were the architect that designed Carter. And so they had experience and they understood what it would be like to be in a room and making sure that decisions are made so the project could progress on a tight timeline. So we're excited about them to, get this amendment, get their staffing up and be ready to be in the field really a little more frequently than a typical designer. So that is our request. Next slide. The next slide shows you the timeline for this assignment. The MWBE utilization plan will still be well over 30%. It will be effectively 33.1%. Here, the designer doing the roof is not an MWBE, so they weren't able to get like the same high exact 36% MWBE participation, but they still have a net of 33.1. And I think the next slide is the resolution itself.
Okay, any questions from board members on this one?
Just one.
Yes.
Is there any commitment to how many women might be hired for these projects?
That is a great question. We can follow up on the workforce
There's
question.
quite a lot of women in
Mhm.
construction these
Yeah.
days. Yeah.
Absolutely. So we actually are partnering with non-traditional employment for women for our own hires, actually. And we can absolutely talk to Consigli about working with new and helmets to hard hats and a bunch of the other, like there's a lot of great workforce development groups out there that we really like to partner with for jobs like this.
Thank you. Any other questions from board members? Okay, so let me call for a vote. Dr. Katz,
Yes.
Dr. Morse,
Yes.
Philip Wadley,
Yes.
Scott French,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes,
Anita Kawatra,
Yes.
and Jose Pagan, yes, so resolution passes. Thank you so much.
Thank you so much.
That's the President's report, Dr. Katz.
Very good, and I'm not going to read it because you have it. The COVID numbers are overall low in the city, but there is a slight uptick up, which is concerning to all of us who pay close attention to the numbers, especially because cold weather seems to increase the chance of COVID spreading as people go more and more indoors. We're doing our best to encourage vaccination, not just the first 2 doses, but there's increasing belief that it makes sense for all adults to get a booster shot if they're 6 months past their prior mRNA or 2 months prior to their J&J. November is Home Care Month, and this is a particularly important year to support our home care workers. It's very hard to hire people for home care work right at this moment. We've had a lot of holes in our workforce, and we want to be sure that we're appreciating the people we have. We're proud to have recognized transgender awareness, which culminated on November 20th with the Transgender Day of Remembrance to commemorate transgender individuals who lost their lives due to anti-transgender violence. We also salute our veterans during Veterans Day. And then I had already mentioned in terms of public affairs that we were very pleased that Dr. Mary Bassett, who was previously on this board and the commissioner of our sister agency, will now be the director of health of the state. And Dr. Cunningham, who I think is still on the call, we're very pleased that she's going to be the commissioner of the Office of Addiction Services and Supports, known as OASIS. We think in both of these cases, these two amazing women will add so much because they understand from the point of view of New York what urban areas need in terms of help encountering both the overdose epidemic and the general health situation following COVID. And then I just want to read for the record that I approved an extension to our agreement with Change Healthcare to support our New York City Test and Trace Corps efforts. Change Healthcare manages call center services principally for our ambulatory care services. They've provided those services for many years, most recently under a January 24, 2020 agreement. In the early days of the pandemic, there were additional scopes of work approved under the emergency declaration to support New York City's response to the pandemic. These include operating the city's COVID-19 hotline, calling persons identified by T2 as COVID-19 positive to encourage quarantine, asking about the need for supportive services and responding to inquiries of parents of school-aged children. Many of these services, which began at various times in 2020, have continued to this date because of the emergence of the Delta variant, the Back to School initiative, and the success they had in managing the infection rate for our city. As the need for the services change, they will be ended, and several have already ended. Due to the continuing need and uncertainty concerning the future of the epidemic, I've approved the continuation of some of these services through June 30th, 2022. The total cost of the program is not expected to be more than $17,223,625, all of which is covered under our agreement with OMB. They will cover that bill. Thank you very much, Mr. Chair.
Thank you. Any questions from board members for Dr. Katz? Let me go through each. Dr. Morse?
No questions, thank you.
Thank you. Hold on a second. Philip Wadley?
All good, thank you.
Scott French?
No questions, thank you.
Barbara Lowe?
No questions, thank you so much.
Robert Nolan?
No questions.
Sally Hernandez Pinheiro?
No questions.
Anita Kawatra?
No questions, thank you.
And I have no questions except just to say that, because I didn't say it before, it's very impressive, all the work that is happening and how fast you're doing it. And that's basically what I wanted to say. So it's good for our system. And I'm glad that we're doing everything we can to provide the best care we can to our patients and to our communities. So the committee and subsidiary reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board? If there is no further business, I declare the NYC Health and Hospitals Corporation Board meeting adjourned. Thank you.
Thank you.
Good job.
Thank
Happy
you.
Thanksgiving.
Happy Thanksgiving.
Very
Yeah.
Happy
good.
Thanksgiving, everyone.
So
Happy
happy.
Thanksgiving, everybody.
We're really delighted.
We're really
Goodbye.
delighted.